Um, so this is about developing community services for people who self-harm. And this is what I'll kind of talk about over the next kind of 45 minutes or so. I'll tell you a little bit about the context to self-harm. Many of you will be familiar with that, but always worth kind of chatting about that, so we know, where this kind of sits. Thinking a little bit about what the current program is, because sometimes there's a little bit of confusion about, what is the kind of community improving kind of services for community self-harm, where does it sit? Talk a little bit about different settings where you might want to focus your activity. A quick whiz through some of the kind of key research evidence and links as to where to find more. And then just lastly, because we're always asked about it, it's just thinking about self-harm and COVID-19 and what the pandemic has meant for self-harm services and what it might mean going forward. So let's start with a bit of context. I just want to start with a bit of historical context. So I've been working in self-harm, been interested in self-harm research for about 25, 30 years. And the question is whether, things have got better over that time, things are still as terrible as ever. And this kind of played out in the pages of the British Journal of Psychiatry last year, actually, where my old friend and mentor, really, Alan House, kind of wrote an editorial saying that we've got nowhere in the last 25 years. We need to do much better. I kind of responded with a more kind of positive piece. I think we've come on a lot. I think we've come on a lot in the last, couple of decades. Certainly, when I started in clinical services, things were not good for self-harm. Sometimes, individual service users aren't getting a good deal even now, but I think they're better than they were. But we've clearly got a long way to go, and this sits as part. That's part of the reasoning behind this current program. But if you want to have a kind of little read of that and decide, have they got better? Have they stayed the same? You make your own mind up. But that historical context, I think, is important. But the other thing that's really important is, the recent context, the recent attention. Lots and lots of attention on self-harm. Is the guidance, the self-harm guidance that we're redoing at the moment. More on that later. So lots of policy attention. What we talk about when we talk about self-harm? Well, this is the kind of nice definition, the definition we use in many clinical services. It tends to be self-poisoning when people present to hospital. In the community, it tends to be self-injury, particularly self-cutting. And we use this kind of, if you like, intent-free definition. So we tend not to talk about attempted suicide or non-suicidal self-injury when we're talking about self-harm, because really it's about being inclusive, and we know even people who are labelled as having non-suicidal self-injury, when you follow them up, they're at high risk of repeat self-harm, of even suicide. So we have this kind of inclusive definition. That's not to say everyone's managed in the same way, but it is to make sure that we're not excluding someone as allegedly non-suicidal, or trying to make judgments about people's intent, because obviously often that's very difficult to do, and it changes. And it's a big problem. Over 200,000 episodes, 150,000 people presenting in England each year. One of the commonest reasons for medical admission. And a lot of you know that when we mention self-harm, sometimes people think, oh, it's just a problem of young people. And it is more common. It's more common in young people, certainly. But one of the really important messages is that it can occur across the lifespan, can affect anyone. It's a paper we did a couple of years ago looking at self-harm in older people. In older people, even more than for people who self-harm in general, there's the risk of suicide. So we know that in the year after someone presents with self-harm, they're at maybe 30 to 50 times higher risk of suicide than the general population, and that's even higher for older adults. In this study, quite a lot of people were, a fair proportion were prescribed tricyclic antidepressants, 1 in 10, when really, we shouldn't be prescribing those because they're toxic in overdose on the whole. only 1 in 10 of people were referred to mental health services, and this is a high risk group. So when older people present with self-harm, it's a bit of a worry. But this is all about what we might do, and thinking about different aspects of needs that we might address. So for older adults, often kind of physical illness, social isolation, or mental ill health can be targets. But self-harm can occur across the lifespan, and we are worried because of its association with suicide. How do we do in terms of services? Well, I thought this kind of Samaritans report last year kind of summed it up rather nicely. It's called Pushed from Pillar to Post, and that's something we hear a lot from patients, from service users, that sometimes care is a bit fragmented. So you present in crisis, you get referred from one team, you maybe don't meet thresholds, you get referred to another, and you end up kind of if you like, being pushed or going from one bit of the system to another. And so really the current program is about kind of making that a bit more coherent, joining that up, thinking about what we offer for self-harm in every area of the country. So this is where the current program fits in terms of the long-term plan, which all of you be very familiar with, the community mental health framework, and actually this major investment in mental health services. So the idea there is really, I suppose the key thing is integration. So seamless services, the old things about kind of referrals into community services, referrals into secondary care, thresholds, barriers. Really the purpose of all this is to make mental health more integrated, to make a kind of seamless service. And as one, if you like, small part of that in some ways is the aspiration to improve support for self-harm. So lots of people on the programme have said, well, what funding have we got for this now? What funding are NHS England giving us for this? And there's no, if you like, additional funding. It really is part of the community mental health monies that all of your organisations will be getting. So it's part and parcel of that. But our role really is to help you think about how you develop the services, what the evidence is around that. And really the ask here is for you guys to develop plans to improve community services for self-harm. So what are your plans going to be to improve community care for self-harm going forward? Our role in that, NHS England have asked us to help you with support around the evidence, to help you develop your plans. So if you want us to comment on your plans, we're very happy to do that, advise you on how we implement things, how we measure things. How are we doing that? Well, in the olden days, it used to be kind of site visits, so we used to come to you. Sadly, that's not the way we're doing things. And actually, because there's so many sites now, because we're hoping to kind of cover the whole country with this self-harm program, the virtual bit kind of works quite well. So this is one of those where we'll group together different areas and hear from you, hopefully a little bit, and also hear about the evidence. You'll get email contact from Debbie and colleagues. Caroline and Leah will run what we call them kind of interactive clinics every month, every 6 weeks or so. Everyone involved in the program can kind of log in, bring issues, bring problems, but also a really important part of this is the shared learning. So we're really encouraging sites to learn from one another. And there's a website as well, which is in kind of constant evolution. So Ian and colleagues keep that updated. Here's what it looks like. There's the link there. So we'll make all the slides available afterwards, of course, and many of the links are in the slides. So it gives you a bit of an introduction to the program, and also has little links to kind of evidence, things like risk assessment, something we've done a lot of work in, assessing services, statistics, that kind of thing. And we're constantly adding to that. And do give us feedback on that. So if there's stuff on there that you'd like to see that you don't, if there's stuff on there that's wrong, do let us know. Two things are, I think, quite important when you're thinking about your plans, and we'll come on to what might be in your plans in a second. But two things are really important. First is thinking about how you implement things. So thinking about a method of implementation. So it isn't just putting something in; it's how you're going to do that. So one approach that many areas have taken is a kind of quality improvement approach. So it'd be familiar to many of you. You make a small change in a service, say a self-harm service, you measure what effect it has. You adapt it, you measure it again, and you make kind of incremental change. So thinking about your method of implementation is really important, but also thinking about data. So, as part of this, we aren't doing the measurement, but it's important that that what you're doing is effective, or perhaps even ineffective. So data is really important, and we've given lots of advice, lots of areas on data. This is our confidential inquiry data dictionary. This is self-harm bit. So there are things, if you like, outcome measures that are directly relevant to self-harm. Self-harm data is surprisingly difficult to get because often it's vaguely coded in hospital records. So someone might be coded as injury, others coded kind of as distress. So it's surprisingly difficult to get good data, but there are some local sources you can use, but also kind of process measures. So, I'll come on to nice quality standards, but are you doing the things that's mandated in local and national guidance? Are you getting maybe feedback from service users? If you've introduced a new service, is that service getting the number of referrals you need? So process measures as well as outcome measures, but do think about measurement when you're developing your plans. Now, all this is going to sound quite daunting to maybe some colleagues thinking, oh, right, we've got to develop a self-harm plan now. Here are some things just that might kind of help ease some of your worries or anxieties. The first is that this is actually the second wave. So we've done this before with the 12 early implementer sites, and the feedback we got was really positive. And here are some of the outcomes from some of those early implementer sites. So what we tend to do is we'll tend to summarize activity in the form of like an infographic. People seem to really like the infographic. So this one's from Frimley, and really they're a key part of their self-harm plan was thinking about psychological interventions, making it timely, making it targeted, an evidence-based psychological intervention, and then also some indication of how they're going to measure feedback. So psychological interventions, Frimley have done that. This is Somerset. They've decided to think about their digital resources. I know a lot of the areas have planned similar things, but they're offered. So the sites, the details of the sites from the website. Other people have, if you like, made a start on this. So it's not hopefully like you're starting from a blank sheet of paper. And of course, many of you, there's lots going on in terms of self-harm services locally. So one thing is thinking about, well, sites have gone before, but the other thing is thinking about how, if you like, the self-harm improvement work fits within other bits of self-harm work that will be going on in your local area. So this is a sequin. This is a sequin for self-harm. So for those of you who don't know, the kind of basically kind of if you like, incentivization targets for health services. If you meet the target, there's a little bit of extra money attached. And from April 2022, we've been trying to get a sequin for self-harm for a long time, but I'm really pleased that in April 2022, there will be a sequin for self-harm. So mental health organizations will get extra money if they're able to demonstrate that most of people being referred into their liaison psychiatry or emergency department psychiatry services get a proper assessment. I'll come on to why proper assessment is important in a while, but there will be people within your organizations leading on responding to the sequin, measuring the sequin, making sure your organizations hopefully get the little bit of extra resource from NHS England. Again, it may be the people on this call that are going to be involved in the Sequin, but it may not be. So do connect with the Sequin lead in your local organisations. The other bit of work that I know many of you are aware of is the NHS England work on suicide prevention. So this is a big programme that's been going on for about the last 4 years, where we're basically every year, we did it in waves, we did it in phases, where different phases, thinking about how they improved kind of their offer for suicide prevention. So this did come with some funding. Areas had funding for 3 years. So Wave 1 sites and Wave 2 sites are Wave 2 sites are actually in the last year of funding, I think, but Wave 1 sites are no longer being funded. And we've encouraged areas to focus on 3 priority areas: mental health patients, men in midlife, and primary care. But one of the priority areas within the QI for Suicide Prevention programme is self-harm, and lots of work going on in the self-harm work. So again, if it's not you or someone on this call, linking up with the local lead for suicide prevention for the QI programme is really important. And again, lots of further links for you to look at should you need. I suppose the other kind of key overarching principle about the programme developing plans is service user involvement. So there's a video of the kind of kickoff event for those of you who weren't there on our website. Hopefully that's the latest one. If it isn't, the latest one will be up soon. But Dr. M was there, and as usual, what she had to say as a kind of service user, someone that's experienced services, had a lot more impact than what I or others might have had to say. Involving service users is, I think, really important. It's really important in terms of engaging people in the service, but it's really important in terms of kind of outcomes and making sure that you end up with a service offer that people are going to use and is going to help people. So there's evidence there that it improves outcomes as well. So service user involvement is key to this. Okay, so I've talked a little bit about the context, and hopefully now you're getting an idea of where the current kind of programme sits. The other thing I think that's really important to think about is where you might develop your services, where you might focus your activity, and it's different settings. And a lot of you will have heard me talk about this before. The iceberg model of suicidal behaviour. So you've got suicide at the top, you've got self-harm presenting to services, if you like, above the waterline, then you've got self-harm in the community. But I think the point about this, developing community services for self-harm, is thinking about people at every level of the pyramid. So it's probably a little bit less the community programme about hospital services for self-harm. That's more covered by the Sequin, more covered by the suicide prevention programme. This is more about kind of community offer, really. So there's going to be people on mental health service workload caseloads with no access, because many services won't routinely provide interventions for people who self-harm. People who present in crisis but don't get follow-up, just referred back to the GP. But then people who, if you like, present maybe to their general practitioners, but don't come to the attention of statutory services, or people who don't come to the attention of services at all. So thinking about what your offer might be for each of those groups. And also, of course, being very mindful that all groups are included. So again, this current programme is focused on adults, but obviously, self-harm services are kind of across the age range. But thinking about what you do for younger people, I think, is really important. Thinking about, is the offer going to differ for older adults, given they've got particular needs, maybe a higher risk of suicide, people from LGBTQ plus communities, and people from ethnic minority groups as well. That's had a lot of attention recently. Why that's important? I mean, the access is the big thing for people from ethnic minority groups. So this is a study led by my colleague in Manchester, Bushra Farouk, and she looked at young people from ethnic minority groups who self-harmed and presented to hospital. And they tended to live in more deprived areas, young people from ethnic minority groups. But the big thing was access to treatment. So everyone should get an assessment after self-harm, but people from ethnic minority groups, young people, were less likely to get a psychosocial assessment and less likely to get mental health follow-up care. So thinking about, is access appropriate for all those different groups? Is there equitable access? Is there equitable access in any kind of development or plan that we might want to come up with? The other thing I'm really kind of quite excited about, I'm really pleased about, is, if you like, this is an opportunity to kind of tap into a new frontier. And I think that's thinking about what we do about self-harm in primary care in general practice. And obviously, we know all the pressure that primary care colleagues are under, have been under for the last 2 years, but in a way they've got a kind of crucial role to play in mental health in general and self-harm in particular. So another study we did a few years ago, led by my colleague Matthew Carr. Now, the first bit I think is not surprising. So basically, dividing the population up into areas where people lived according to deprivation. And the people living in the most deprived areas had the highest incidence of, if you like, of self-harm. So deprivation, we know, is associated with mental ill health. And, in this study, it was associated with self-harm. So people in more deprived areas are at greater risk. But I think the really striking thing is when you contrast that with the number of people referred to mental health services. So people in the most deprived areas had the highest incidence, if you like, of self-harm, but the lowest proportion were kind of referred. So highest incidence, lowest proportion in the most deprived areas. So that's public health colleagues will know this, very well. It's an illustration of the inverse care law. So sometimes care is provided kind of inversely kind of proportional to needs. So this is, I think, an important part of that. So thinking about what we do in primary care, but also I think the message from this slide is about kind of social inequities. In this study, quite a lot of people receiving psychotropic medication, not a lot of people being referred to mental health services. A big study in primary care. What might primary care self-harm prevention look like? So this is a systematic review by Faraz Mughal in Kiel. Here are some of the things that might improve care for self-harm in general practice. A lot of this we're very familiar with you. Here are some of the barriers, and again, I know, local factors, systemic factors, barriers to referral, etc. So encourage you to have a look at that if primary care is one of your areas, which it should be. Educational settings, schools for younger people, but in the context of this program, higher education universities. Many universities are really hot on mental health, are really hot on self-harm and suicide prevention, and there's some links there if that's an important part of your local kind of environment. Links with higher education is important. And another key principle, I think service users being involved, that's a key principle, but I think the other thing is just thinking about how we involve kind of third sector colleagues who've done a splendid job over the last kind of couple of years in supporting people at risk. The two obvious ones are Harmless and Samaritans, who, as well as, many of you will be familiar with them as websites or providing information, but they're actually service providers as well. So, Harmless are commissioned to provide services somewhere. Samaritans locally, will help follow up people who, either left without an assessment or haven't received one. So, in many areas, they're helping support statutory services and really key to kind of getting them involved in this. But also involving families, not just for young people, but for others as well. There are lots of kind of again resources out there involving families. One of the things that often comes up is confidentiality. So, we can't share information because it's confidential, and obviously we have to respect confidentiality. We have to respect clinical information. But I think the Department of Health's position, and this is from the Zero Suicide Alliance, is a really kind of sensible one, which is actually, we should ask people, we should give them the opportunity, and almost it should be a default, as long as people are happy, that we involve families, because we know that leads to better outcomes. So really guarding against the danger that we as services, we as professionals, if you like, hide behind the confidentiality in order not to share information. Really, the default should be, obviously with people's consent, that actually, we get better outcomes. People are better supported in general if we involve families. Obviously, there are exceptions to that, but thinking about confidentiality and how we share information, but involving families, I think, something else that's really important. Okay, we'll move next on to kind of evidence, and this is a very quick kind of run through some of the evidence. I'm not going to labour some of this, and if you like, we're quite lucky in a way, because much of the evidence has found its way summarised into nice guidelines. I was 2004. I'm just looking at that date there. 2004, the first nice self-harm guideline. There was an earlier Department of Health guideline that dates from 1980, but the first nice guideline in 2004, and since then we've had the 2011 guidance. Here's the quality standards for self-harm, which really was in some ways a summary of the 2011 guidance. And as I said, we're working on the new self-harm guidelines. You've got a little bit of time if you want to respond as a stakeholder, so you can have a look at that. That's a draft guideline. Many of your organisations will be registered as stakeholders. I know many people have already submitted comments. It's a really important part of the process, so we can make sure the guideline is fit for purpose. But if you like, that's a good kind of summary, if you like, of the evidence and what it means for people. The other thing that often comes up is training, and what's the evidence around training. There's not huge amounts of research evidence around training, but one of the things we do point people to are the competence frameworks that we developed a couple of years ago. The separate ones for adults and older adults, younger people, and people working in non-specialist settings. And basically what that maps out is what we'd expect staff to know in terms of kind of attitudes, key areas of knowledge, how, what skills would we expect staff to have? And you can click on each of these boxes and basically it comes up with a list. And I mean, what we've encouraged individual areas to do is often they're providing self-harm or suicide prevention training already, and it's really kind of auditing it to make sure you're covering all the important areas. Other times, people are wanting to commission self-harm training or suicide prevention training, and it's tricky because obviously sometimes it's people are charging for the training, etc. And we'd encourage people just to check any training they've commissioned or are considering hit some of these targets. I think would be good, but I think that's quite a useful starting point for training, because I think lots of areas involved beyond training. What helps? Well, the first thing that helps after self-harm is making sure people are properly kind of assessed. And you might think that's, well, of course we'd assess people if they presented to services, but actually almost half of people when they present to hospital, even when they present to hospital with self-harm, don't get assessed. And we contrast that with some of the data that we and others have produced, that just getting an assessment might reduce the risk of repeat self-harm by 40%. How does it do that? How does an assessment kind of work? Well, it's something about the connection. It's something about plugging people into help. This is a lovely study done by my colleague Leah, who unfortunately not here today. She's on leave, but where it's a qualitative study thinking about what helps. Asking service users what helps. So a lot of this is obvious. Humanising care, something that's collaborative. Having a bit of space and time to talk, compassion, and then actually receiving the help. So something about the interaction between the individual clinician, the individual professional, and the patient or service user, and then something about aftercare, receiving aftercare. So really, I think, really important that we make sure people get assessed. And again, there's a link to the paper there. But it's not just about what happens when people present, it's about what happens afterwards. So talking treatments, I think, psychological interventions for people who self-harm are really important. Why are they important? Well, here's a nice busy slide, but all I want you to look at is this diamond here. This is a forest plot, so it just summarizes lots of randomized trials for people who self-harm. And the bottom line is, if people get a talking treatment after self-harm, they're about 30% less likely to repeat than people who didn't get a talking treatment. So providing talking treatments after self-harm is a really good idea. People always ask me, well, what talking treatment? This is another review where they kind of looked at, whether they could tease out, whether any of that made a difference. And they couldn't find a difference between type of therapy, the intensity of therapy, or the site of therapy, i.e. whether it was at home or in hospital. Sometimes you get better retention rates if you're going out to people in their own homes, but really, I think this is about providing something evidence-based and not worrying too much about the exact modality, whether it's interpersonal, cognitive, behavioural. Getting something evidence-based in there, but getting it in there quickly. Why do I say getting it in there quickly? Well, here you go. This is the time to repeat self-harm. So this is how quickly people repeat self-harm. And the answer is, if they're going to repeat, they repeat quite quickly. So this is people who repeat within a year. If you're going to repeat within a year, 30% of those people repeat within the first month. And actually, you can break it down further. So 10% of people repeat within the first 5 days. So if you're going to intervene for self-harm, sending an outpatient appointment in a couple of weeks, putting in a referral to CMHT for them to be seen in 3 weeks, that's a bit of a waste of time, really. What you want to be doing is, if you're wanting to intervene, get in there quickly with an evidence-based psychological intervention. Very good. Right, I'll just kind of whip through a few more other things. The other thing that comes up a lot is risk, and how we should kind of predict risk and how we should use tools. Actually, tools and scales and other things to predict suicide after self-harm are pretty poor. Positive predictive value is 5%. What does that mean? That means that if 100 people are at high risk, I rate 100 people at high risk, only 5% of them will be at high risk. In other words, they're wrong 95% of the time. But that isn't even the biggest problem. The biggest problem is all the people that services that we rate as low risk, because that's a big group, we miss all the people there. So this is a problem. It's a problem about kind of exclusion. It isn't a problem of simply getting better instruments. Risk assessment after suicide, risk assessment after self-harm won't kind of give you the answer you need, especially if you're trying to use it to allocate treatment. So risk assessment as risk prediction is a kind of fallacy, and we've talked. There's lots of research published by ourselves and others that shows that. Digital interventions, that's something that comes up again and again and again. What's the thing? Should we be finding digital interventions for everyone? As a recent trial, I only saw it yesterday, so it hasn't made its way into slides from the US. That didn't show it was much better. A kind of package of digital interventions was much better than treatment as usual. But we know from more kind of the wider reviews that actually they might be helpful. But it's even with systematic reviews, different people look at the same evidence and reach different results. So these guys said, well, we need further research. And Helen Christensen and colleagues in Sydney say, well, they should actually be promoted widely. What's our view of the evidence? I think they definitely can be helpful. There's evidence for efficacy for depression, for other things, and for self-harm and suicidal ideation. I think one thing the pandemic's taught us is the importance of choice. So that's the advice we're giving kind of locally and further afield. But yes, there is a bit of an evidence base behind some of these interventions. It shouldn't be the default. I personally think, certainly from the point of view of assessment and interventions, for some individuals, you get things that face-to-face that you obviously wouldn't be able to pick up online. For others, they prefer online, and obviously there's the access arguments, both increasing access, but also the notion of digital exclusion. But I think digital interventions obviously here to stay. The last 2 years, I think, have, if you like, speeded up development in that area. Okay, in the last 5 minutes, I'll just talk a little bit about self-harm and COVID-19 because it's something we're asked about. Obviously, I don't know, I mean, I find it really hard to kind of remember what it was like 2 years ago, almost 2 years ago, but, you know, here's a headline from that spring, that first kind of spring, you know, deep lockdown. And this is what people were worried about, the massive effect on mental health, on suicide, on self-harm. What's been the effect on mental health? I think, you know, the evidence is pretty clear. There's worldwide evidence. This is early evidence, actually, from colleagues in Manchester, that I think showed, you know, pretty kind of robustly that COVID-19 did have an impact on people's mental health. So this is, if you like, a repeat survey, so a longitudinal survey. And, you know, this is questionnaire based, so you have to bear that in mind, but this is clinically significant mental distress on a questionnaire, basically went up by 10% during that first early lockdown. And there's lots of evidence around the world to say it's had an impact on mental health. But what's been the effect on suicide and self-harm? I mean, suicide I won't talk so much about today, but, you know, it's very interesting that, you know, in general, rates of suicide have not increased in many areas. In many countries, they've actually fallen. For self-harm, this was a kind of early summary. This is self-harm, a study from my colleague Sarah Stee. Self-harm in primary care, but a big study. So the yellow line is previous years. The purple line there is what happened in 2020. And the most striking thing is this reduction in self-harm presentations to primary care in the early part of the pandemic. And you know, what I'm not saying here is that self-harm incidence decreased, although, you know, it wouldn't be implausible totally, because suicide rates did, we're thinking, decrease early on kind of worldwide. But, you know, this is probably a reduction in help seeking, people being told to protect the NHS at this point, people, you know, being frightened to access services, some services not being accessible at that point, especially for people with self-harm. So this idea of people not seeking help early on in the pandemic, and that was echoed in these national data from France. You know, all these age groups here during 2020 were less likely to attend for self-harm in 2020 versus 2019. So reduction. What was quite interesting though is for older age groups, there was an increase. So for older age groups, they were more likely to attend with self-harm in 2020. And there was also this increase in acuity. So this is something a lot of colleagues talked about, that, you know, in the first lockdown and subsequent lockdowns, fewer people might have presented, but actually people who did present were more unwell, led to more ITU admissions, led to more deaths. So, but overall, no effect. Overall, a reduction. Overall, no effect on suicide, but a reduction probably in help seeking for self-harm, both in primary care and secondary care. But what about community self-harm? What do we know about community self-harm? This is from the UCL survey, massive survey. They don't have pre-pandemic data, but, you know, brilliant data post-pandemic. No effect actually. You know, over the past 18 months, people reporting self-harm has stayed fairly static. This is just a reminder, though, in people with a mental health diagnosis, they are reporting higher levels of self-harm than other people, but nothing in terms of trends. So a fall off in help seeking from, you know, if you like, health services, but no differences in the community incidence. So the question is, where were people going? The data on this is a bit variable, but this is something about, this is from calls to helpline calls. This is international data, it's not UK data. And basically, you know, more people seeking help from, mental health helplines. Not universal, actually. So there's other data suggesting that the increases in call volumes weren't as great. Some other data suggesting that the duration of calls increased. But in this study, you know, it's 21 helplines. They did see an increase in calls to helplines. So, you know, again, a role for the voluntary sector. Interestingly, though, not about kind of suicidal ideas or self-harm. This was about the calls were about financial worries, worries about the pandemic itself. So, but you know, if you like, voluntary sector colleagues, taking some of the statutory, perhaps take, some of the workload, if you like, transferring to the voluntary and third sector. Going forward, what's been happening since, this is just some local data from Manchester. What you can see, I mean, it's kind of a bit up and down. These are self-harm presentations to Manchester emergency departments. During the lockdowns, a reduction in help seeking, probably a reduction in people presenting with self-harm, and then more recently a kind of return to if you like kind of historical levels. But I think some areas have reported kind of increases in 2021, other areas have reported decreases. But I think the further on we go, the less likely some of these trends are to be directly related to the pandemic. But I think the important message is that during those lockdowns, we saw a reduction in help seeking, and I'm not certain what the effect of all that is going to be, and whether actually now things that are opening up, we're going to get more presentations, more people seeking help. Because the other thing, of course, is it's not over in terms of the effects. The ending of the restrictions, people have different views on those, but some of this is going to continue to play out in terms of work, in terms of the economic factors. The latest thing, of course, is the cost of living squeeze, and that's going to impact on people's mental health, and also their probably rates of self-harm. So I think one message is all of us need to keep an eye on self-harm, need to keep an eye on suicide, but thinking about developing our services for self-harm, I think it couldn't be a more exciting time, if you like. We've got an opportunity here to do something that we've not managed to do over the last 3 decades. But the other message is the evidence is still the evidence, and I know many colleagues struggled during the pandemic in terms of service provision for mental health service users. I think even now there are many service pressures, but one of the really important messages I think is the evidence is still the evidence. So the stuff in the NICE guidelines, the evidence here is for suicide and self-harm prevention, really. So the economic mitigation we know will work for hopefully helping to mitigate some of the effects on mental health, keeping kids at school, but also understanding the impact of what's gone on, the importance of research, the importance of evidence. So the evidence is still the evidence. We've got quite a good evidence base. For self-harm, we've got the guidelines to help us, and the challenge is really applying that in a different context, in services that are pressured, in services that are responding also to the pandemic. But the evidence is still the evidence. We've got an evidence base there, and I think a real opportunity. So I've talked a little bit about the context and the current programme. Hopefully you're clear on where this sits. I've talked a little bit about the importance of how, when you develop services, you think about the different settings you might want to kind of focus on. A little bit about the evidence. There's a lot more to kind of say about that, and that often comes up in the virtual clinics. And then just a brief snapshot of what's happening with self-harm and COVID-19. So thanks for that. I'll just put up a quick slide of some of the people are, of course, on the call. Others aren't. These are all the people back in Manchester who do all the hard work. So I will stop sharing there. That was a bit of a whistle stop kind of tour to the programme. I'll just pause there for a second. I think we'll kind of take questions afterwards, but anyone got anything kind of burning they want to say in response to that? I'm just giving you a kind of bit of a breather, and just giving Kate a bit of time just to kind of catch her breath before handing over to her. Okay, I'm not seeing any hands up. So, okay, so what I'm hoping to do now is just hear from, I think, Kate and Renee, just about, activity at the moment, what your priorities are at the moment, and then we can kind of hopefully link that into a kind of broader discussion. So over to you, Kate.
Thanks, Nav. So I'm going to give a bit of an overview, if that's okay, but then Lucy's going to chip in and just dovetail what I say, I think, with some of our Wave 4 suicide prevention plans and how
Fantastic.
it links up, if that's okay. And then I will give the opportunity for any other colleagues just to add in anything that I might have missed.
That's fantastic.
Just for a little bit of background, so we had a management trainee working in our system last year who undertook a piece of work for us, mapping our self-harm pathway against best practice. So within that piece of work, the trainee did review a lot of the engagement that had been undertaken across the system around self-harm. So we've got a number of reports that we were able to draw on, so we could get that lived experience view within that mapping, including health. Our local health watch had undertaken quite a big piece of engagement about access to self-harm services. There'd been some work undertaken as part of a joint strategic needs assessment, and also some work specifically looking at children and young people's early intervention support, more broader than self-harm, but some of the themes that came from that applied. We also looked at some of the national reports, such as the Samaritans one that you touched on, Nav. And from that work, I think what that drew out was probably a lot of the gaps in provision that you've already articulated, gaps in access to evidence-based interventions, gaps around IAPT and where they do or don't accept people who self-harmed, communications of like what the pathway is and what the service offer is. Training came up as a gap, waiting times, waiting lists, people kind of feeling like they were bounced around the system quite a bit. So that work generated a set of recommendations, and broadly those recommendations are about looking at self-harm training across our system. Quite a big focus on primary care as part of that. We wanted to undertake a piece of work with our IAPT providers to ensure that they don't exclude people who self-harm. I've got a question for you that I'll pick up when we come to the question and answer section a bit later on, but looking at whether we can give them some specific self-harm training and also some access to some supervision so that they can have some support and manage people better. We've got some recommendations about communicating our pathway as it develops. So our children and young people's leads have recently developed a really good resource called Not Alone. So it's a website and talks about all the different services available for around mental health. And there are sections there for young people to access, for professionals to access, and for parents and carers. So one of our recommendations is to build on that for adults, so it goes across the whole age range, and there'll be sections on there for accessing self-harm specific support. One of our other recommendations, Nav, was around reviewing all the learning from the 12 early implementer sites. So hopefully we can link into yourselves on kind of drawing out that from all of those sites and what each of them have done. Some of the recommendations we had were around waiting list management processes, and whilst people are waiting for an intervention, what is it that they can access in the meantime? And some of that's like your digital resources, your national and local helplines and things like that, and making that much clearer. And also some work with our system partners to identify where people who self-harm might be presenting for medical attention, but making sure that those organisations have got the right training, understand the pathways, making sure all that's in place. And some of that's in relation to like sites such as like our urgent treatment centres that sit a little bit on the periphery, and is just trying to understand if they've got the right kind of offer in place there. Through that work last year, we have commissioned Harmless, so they're providing a all-age suicide crisis and self-harm service across our ICS. So that offers stabilisation and then self-harm specific support and therapy in line with NICE guidelines. So that's a really good development for us. And then some of the colleagues on the call are the leads for our community mental health transformation programme. So obviously we've just refreshed our plans for that and submitted those last week. But there's some pieces of work within that transformation that are kind of really key here. So Louise and Glenn have just recently undertaken all the recruitment of mental health practitioners in PCNs. And I think as an ICS, we've been really successful in that recruitment programme. So Louise, we've got 16 whole-time equivalents now coming into post in those roles. 16. And I suppose we need to look at where they sit in relation to supporting people who self-harm and what interventions they might be able to deliver. We've got a specialist tier 3 hub for the personality disorder pathway, offering consultation and support to our wider system. And again, we need to look at how that supports around self-harm. And then we're working to increase access to psychological therapies across the whole pathway, in introducing like new roles, different ways of working, but also working with some wider voluntary sector partners such as Mind and Turning Point, who are delivering as part of that transformation. So they're not self-harm specific interventions, but I think we need to think about how we work with those organisations in the context of self-harm as well, and people coming through those pathways. And then a couple of colleagues on the call, so Claire and Alison and Louise, are part of undertaking a psychological therapies review currently, looking at the psychological therapy offer and looking at that through the community mental health transformation lens. So that work's ongoing at the moment, and I think just devising a new model currently. And then a little bit broader and outside of that, just so you know, we've also got crisis sanctuaries in place across our ICS as well. So we started those last year, and they've probably got quite a key role to play in people presenting in a crisis who may have self-harmed as well. So I'm going to pause there, and I was just going to hand over to Lucy just to update a little bit on Wave 4.
No problem, thanks Kate. So yeah, we started our Wave 4 programme funding this year. The specific things that I think are really relevant to the self-harm work that we're talking about today: training comes up a lot in our conversations across the system. So we've got quite a big focus on training in our Wave 4 plans. The way we've tried to describe that is it's not just about kind of skills and knowledge, it's around people having the confidence to have those conversations across the whole system. But there's also an element of compassion in there as well. So I think that came across really strongly from the session that you did before Christmas, Nav, around people being treated with respect and compassion. So that is a really big priority for us within Wave 4. We've recently commissioned the Institute of Mental Health to do a system-wide training needs assessment. So what we're looking for there is working with a really wide range of our system partners to understand what training's in place, what the training needs are, and how does that align with some of those competency frameworks that you touched on earlier. So that work is taking place now at the moment. We'll be using that to kind of make recommendations across our whole system. So we're planning to have a whole suicide prevention strategy group meeting dedicated to reviewing the findings of that needs assessment. Part of that will be about feeding back those recommendations to system partners so that they can consider that when they're developing their own training programs. But we have also ring-fenced some of our Wave 4 money to provide some training as well. So we're working collaboratively across Notts County Council, the City Council and the CCG. So we'll all be party to that framework agreement, and hopefully we can use that as in a very planned way across the whole system. So training is a massive focus for us. We have also ring-fenced some Wave 4 money to pilot different ways of working around self-harm as well. So obviously the Wave 4 money isn't a huge budget, but we've ring-fenced a little bit of that to pilot new ways of working as a kind of test, learn, build approach. One of the things that we're possibly looking at with self-harm is some sort of collaboration between our community and voluntary sector services and IAPT provision as well, to understand how they can support and enable that access to people who are self-harming through IAPT. Comms is also another key element within our Wave 4 programme. So we are working with system partners and people with lived experience to develop a really kind of strong identity for our suicide prevention and self-harm work across the system, and that will include self-harm and link with that online resource that Kate touched on. Other things that we're doing is co-production. So I think we've got a question around that at the end that we're hoping for some help with. It's been a bit of a slow burn process in terms of getting our co-production system up and running as we'd originally intended. So at the moment we're just exploring other opportunities to kind of do some interim co-production work while we grapple with that issue. Kate's touched on some of that kind of wider system work. We're really, really keen to understand where else people present for self-harm, and how do we engage with those organisations and make sure they give the right response in the right way, and that we're linking people into that psychosocial assessment. So I think Kate touched on urgent care. Another key group for us is primary care and pharmacy as well. So we are planning to develop a suicide prevention, bereavement and self-harm support pack for primary care and pharmacy, and roll that out hopefully in the coming months. And the other key focus we've had is around further and higher education. So we've set up a further and higher education suicide prevention network that will also encompass self-harm. So that's about really understanding like what are the offers around self-harm support across that system for further and higher education students. So we're doing a piece of work with them as well. And then we've also set up a suicide prevention stakeholder network. So we're engaging really broadly with a whole range of system partners. Self-harm will obviously be part of that work. And I think our first session's this week, and I think we've got about 80 people signed up to that already. So we've got really good reach across the system for that. I think that's probably it from me.
Just to double check if Louise or anybody else wanted to add anything from Nottinghamshire. Did anyone want to add anything further, or do you think we've covered where we are at the moment?
I think you've covered most of it, Kate. I suppose it's just to sort of add that from the SMI transformation sort of point of view and the programme that we've got in place, and there's various different sort of work streams. And I know that, Kate, you mentioned the one earlier around sort of psychological therapies, and there's one around primary care and voluntary sector. And I think that, you know, what we said was sort of for the self-harm plans, it's weaving it into all of these because it touches every single pathway. And we need to make sure that it's part and parcel of the plan. So linking into sort of some of the system work that's happening and making sure then that's integral to the plans we've got around sort of the SMI programme as well, and sort of within the work streams. And so really just to put forward that in relation as well to sort of the training recommendations and around sort of the training offer that we'd have in place as well for sort of staff within those teams. So yeah, but I think you've covered everything else, Kate.
Fantastic. Can I just make a comment? I mean, I just want to congratulate you on that kind of astonishing effort, actually, because although you're not in the early implementer sites for this program, you're ahead of many of the early implementer sites, if you like, and I think what's really important, I'm glad we're recording this, because I was thinking, I've been scribbling things down as we go, and I'm sure Debbie's kind of scribbling things down, but how do we kind of capture all this? But actually we've got it all recorded, haven't we? I just think the breadth of activity, the areas where you're intervening are really helpful, and will be really helpful to other sites, because I'm sure this level of activity isn't going on everywhere. The other thing I think is just how the fact that Lucy, you're here as well, Kate, the idea that this sits alongside the wave 4 in your case work. I think that's absolutely kind of fantastic. So that I think is a kind of model for other areas. There's lots to talk about there, which we'll pick up, and I know both Lucy and Kate, you've got a question, but we'll pick that up in a second. I suppose the only other thing I'd suggest on the basis of what you heard, but I'm sure you're going to be doing it anyway, is just linking in with whoever's leading on the kind of sequence in the hospitals in your patches. So it'll be the liaison psychiatry lot who hopefully know about it. We've got something like 400 people on the liaison psychiatry webinar. I mean, I much prefer face-to-face events, but you do get lots of people there. So there is. So link with them, because then you'll have the complete kind of, if you like, the complete kind of package. But I just want to kind of commend you and congratulate all of you on what you're doing. And, I think it's very helpful for us, because we can, unfortunately, for you, it means, we'll be pointing people in your direction, say, actually, you need to have a chat with Kate, Lucy and colleagues, because they're doing this. So That's fantastic. Rennie, it's always difficult when someone's kind of they're well established, they've been doing lots. But I think one of the things about this program is people are very much at different stages, and we kind of learn from each other. But I don't know if you can say anything about what's going on locally, what areas you want to focus on, what your priorities are locally.
Thank you for that. I've just joined, being told to join, so I'm not probably gonna give a true representation of Shropshire, unfortunately. But thank you for all the suggestions that you've given. It's definitely an eye opener, because I don't really touch all the areas across Shropshire, and I'm not linked with everybody across Shropshire. I'm probably not going to give an adequate picture. But we do have a Shropshire Suicide Prevention Action Group, and we've just been looking at refreshing the action plan currently. We're not going to change the strategy at the moment. We're having a refresh. We've had lots of work groups currently looking at kind of what areas we can look at and how we can improve them. We do have training for suicide prevention. We do that with joint training with adult social care. We do with children and people as well. So we did have some training programs with suicide prevention, such as STORM, which is skills-based training on risk management, which also had a module that covered self-harm, which was really well received. Currently looking at maybe what we can do across the workforce, and of course the digital is what we have, such as Together for All is something digital that we can access. For the workforce, currently at the moment, we probably use Zero Suicide Alliance that you've mentioned before, that everyone can access. We have kind of different tiers of kind of what people want to look at and kind of suicide awareness. I mean, that encompasses self-harm as well. So with safety planning and kind of intervention focused self-harm as well. We've had a voluntary sector, we worked voluntary sector as well. So we worked with Harmless Have Come and delivered some training as well. And we work closely with Samaritans that are working within the community, talking about difficult conversations. So we worked with hairdressers and currently, and we're looking at expanding to hospitality as well. So we work very much have them working with us, and invaluable resource, and our local mind as well, that we work as well, because we've just kind of looked at kind of suicide bereavement is something that we've just started as well. So we have a suicide bereavement pathway, and so offering kind of support to people after suicide, and developing new things like some groups like SOBs is something that we want to develop. We've also just literally got some funding for some postvention for the NHSE. So that's going to be used to enhance and involve the existing suicide bereavement service, development of a tiered approach to trauma-informed support and counselling for people bereaved by suicide, bespoke bereavement and trauma awareness training aimed at those supporting children and people and families. Like I say, the SOBs group we want to set up as well, and use of promotional material, design, printing and dissemination. So we don't really specifically have a self-harm lead. So I think it's wanted to come to today's meeting to really just kind of have an idea of gauging of kind of what other areas are doing and how we can go forward, and kind of linking with kind of what we're kind of doing at the moment with very limited funds, obviously, and seeing how we can work, like you say, with the third sector and existing providers and services that we have together. As part of the ICS, we have currently just had an audit of provision, and we're looking at kind of specifically children and people services and what we can do to kind of look at what kind of provision we already have and how we can kind of streamline those provisions and kind of make sure we can provide services as and when we need, because we know waiting times are something that is kind of stressed, something that we need to kind of work on in terms of trying to limit them waiting times. So I'm sorry, it's not.
No.
Something we do use in terms of evidence. We've got we've just started real-time surveillance as looking at evidence, and we are looking at the fingertips as well to look at local evidence in terms of supporting what we're using in terms of our plans and provision going forward.
Thank you, Rennie. I just want to reassure you that was really helpful, really valuable. It sounds, your experience, I'd just like to reassure you, is more kind of typical. It's not often that we'll come to these and have a kind of fully developed, massive kind of program that's all linked up. So your experience is more typical. So I just want to kind of thank you for coming and just reassure you. I suppose, it's you mentioned one thing that I didn't mention, which is actually there's the suicide prevention program. There's actually the suicide bereavement program as well. And sometimes people say, well, what's that got to do with self-harm? But of course, it's all kind of linked up. So that's another important link to make, which you've done. I guess the challenge for you is going to be, if you like, convening the right people and getting the right people around you. And I think, what we've found is often, although this is about community services for self-harm, local, liaison psychiatry, mental health clinicians are often interested in the area, so can help. I think the other thing to do is to link up with the, if you like, the suicide prevention lead. I can't remember what wave you were in for the QI work, but Debbie, if we could maybe just look up the link person for Rennie to contact, and then with your local mental health, with your local liaison psychiatry services, just find out who the link's going to be for the sequin. And if you like, it's the mirror image of this program. The sequin's really going to be about psychosocial assessments in hospital, and the community program, this program, is more about, if you like, the mirror image of that and what's happening with the community. But involving those people, I think, will be absolutely fantastic. But you've already got a bit of a kind of start, so I don't think you're starting with a blank page, because there will be, I think, significant amounts of activity going on in relation to self-harm in your area. You just need to find out where the activity is, and part of the job of this program is kind of linking that up. I'm just wondering if Kate or Lucy might be able to provide a little bit of kind of advice about the kinds of people you needed to involve kind of early on in order to kind of get a critical mass of enthusiasm. Kate, I don't know if you want to start.
I think a lot of this came through Lucy's work in the suicide prevention strategy group. So that's multi-agency and brought together a lot of partners, and that's driven, hasn't it, Lucy, a lot of the way forward work. And the self-harm mapping work was almost like not a precursor, it's one of the actions that fell out of that, wasn't it?
Yeah.
And again, that had a steering group last year driving that work, and that brought together different agencies to shape that pathway. I will admit, Nav, that we probably feel like we're almost at the start of a journey as well. Yeah. That mapping work that happened last year, I suppose it's generated a set of actions, but we're now trying to work out where they sit, the governance around it, who the kind of project team are, I suppose, delivering on some of this. All that still needs working through. And I think, lucky for us, we had a bit of a pre-meet yesterday with colleagues on the call just to say, like, where are we collectively? And that's helped to bring some of our thinking together, but we need to formalise some of that as well outside of here.
Yeah, I absolutely. I can appreciate, in some senses you're at the beginning because you started with the mapping and stuff, but actually, your pre-meet yesterday and just listing what you've got, because I think part of the trick here for this program, people are saying, oh, well, how on earth are we going to set up new self-harm services, as part of this program? How are we going to do that? And it isn't about that. It's almost about harnessing what's going on locally already and thinking about how we bring that together and then kind of tweak it. So I think, you've done that really, really well. Lucy, any advice for Rennie about, getting that critical mass together, or how, key people she might want to try and get hold of?
Yeah, I think Kate's right. Our suicide prevention strategy group have been really key to this, and we did a piece of work last year to actually reduce that group down and give it a tighter focus. So certainly key for me is our trust lead on suicide prevention and self-harm, who previously worked in liaison psychiatry, so that's a really good link for us. We've also got analysts involved from our liaison psychiatry team as well, so that's incredibly useful. Our police force are very useful as well, so they obviously have a lot of issues with self-harm, and I know Kate would be able to explain this better than me, but the triage service that they've got within the police is incredibly useful information. And we've got a really strong partnership between the City Council, the County Council and the CCG, which I would say has been absolutely key, along with Notts Healthcare Trust.
Thanks very much. Caroline's been working in kind of self-harm for many years. I mean, Caroline, I mean, we've talked about liaison psychiatry teams. Are there other people kind of, you know, that we kind of engage in Manchester, or, you know, are there other, if Rennie's kind of starting out and trying to draw people together, I'm just wondering, you know, if you've got any thoughts about additional people.
I can't really think of any off the top of my head.
Oh, I've just thought of another one. Primary care, I think, is going to be really important for us going forward. So we've just started kind of engaging with them properly, but the CCG team that kind of oversee primary care have been really helpful in that, and we've got some good primary care reps.
That's fine, yeah. I suppose, you know, Caroline, you and I are mostly kind of focused on liaison. It's hospital services, and I think, you know, many of the other areas have been kind of covered really. Louise?
Yeah, it took me ages to find the raise your hand sign on it. I don't use very often.
No, a lot of people are on Teams. So for those of you who are unfamiliar with Zooms, it's on the reactions button. So well done for finding it, Louise.
Yeah, I was just going to mention that I think as well, you know, sort of the links we've got together on the programme, and I think the developments with the transformation programme, particularly in primary care with the mental health practitioners, that's given us sort of a new level of collaboration really with primary care. And I mean, those roles have got a foothold both in secondary care and in primary care as well. So we're seeing them as quite a bit of a linchpin really for some of this work. So I'm not sure sort of where things are at in Shropshire with that, but it seems like a really good opportunity to utilise those roles and those sort of collaborations and the links made with those roles into primary care. We're seeing much better working relationships and understanding of each other's services. We can get comms through really quickly as well, because we've got people actually working in the GP surgeries now. So it really has sort of improved things quite dramatically already, and they've already been in post since November. So I think that's a real sort of opportunity as well, is those developments around those new roles and those roles that work across teams really.
Thanks very much. So Rennie, hopefully a few ideas there to start, and, you know, be in touch, get in touch with us, get in touch with colleagues, you know, some of the other, I don't know, Debbie, do we have the links? We won't have individual people's kind of email addresses on the website, will we, for the other leads? But
I've just actually sent Renee an email with the link for Shropshire STP. Okay,
brilliant. But I'm just thinking in terms of contacts for the other self-harm programme leads in the early implementer sites. We haven't got those, but Rennie, if you wanted to know, you know, who was working in the area locally, we haven't put them up on the website for obvious reasons, but we could share those, couldn't we?
Yeah.
Brilliant.
Thank you.
Fantastic. Okay, so Kate, I know you had a question about IAPT, so maybe take that one first.
Thank you. Yes, it was. So as part of that mapping work, one of the things that came out of that, which is, I think, well known across the country, is I suppose a lot of IAPT services will exclude people who self-harm, and that came through when we spoke to our local services, in the majority of them saying that. So what we were thinking is how can we change that? How can we enable that? The IAPT manual has obviously changed to say it shouldn't be a blanket exclusion, should it? So that's great, and we will use that. But actually, what support do we provide to our IAPT providers to enable them to work with people who self-harm? So what we were going to look at was some training, some self-harm training and some supervision. But I just wondered if from any of the early implement sites or outside of early implement sites, if you've seen any developments that have enabled that to happen.
So I haven't seen anything IAPT specific, but there is a real kind of need for that. Various people, lots of people, both in the suicide prevention work programme and the self-harm early implemented sites have thought about training, but there are no surprises there. They're the kind of things that you'd expect. There's the zero suicide stuff. There's the Health Education England stuff. There's an hour-long kind of video there. There's some stuff on the MASH website, I think, Caroline, isn't there? That's very helpful in terms of the training stuff. So there's all that kind of generic stuff. The key thing, I think, would be mapping it to some of the competencies, but actually it's even more kind of obvious than that with starting something like this in IAPT, which is actually, I think you mentioned it, Lucy, which is about giving people the confidence when talking about self-harm, because I think a lot of this will be actually, oh my gosh, someone hurting themselves, we're expected to give them psychological therapies, what happens if, so there'll be a risk element of that. So reassuring people, giving people kind of the information about self-harm, the kind of stuff that we've talked about here and at other meetings, about self-harm. Yes, it's associated with suicide. Most people don't go on to die by suicide. There's evidence-based things you can do to make a difference. And one of the things that I've often found very helpful message when I'm talking to practitioners is, just the contact you make with them. But just that contact, if we look at some of the research, just that contact is going to reduce the risk of repetition by 40%. So you're doing some good every time. But it's about giving people the information, giving people the confidence, having links with the kind of infrastructure. So risk comes up again and again. What if bad things happen? What are the so reassuring people that there's a robust support mechanism in place, both for them as practitioners, so that they feel the organisation has their back, but also in terms of what sometimes things would go wrong, and what we'd be expected to kind of improve. I mean, learning cultures, all the rest of it. So I think those things are really important. And the other thing I think that's vital with IAPT is the supervision element. So what you can't do is ask them to start and then not have any access to ongoing supervision. So I think that would be fantastic. My other advice to you, I think, would be to start small. So if you want to pilot it with one or two really keen IAPT practitioners, and then kind of build outwards, that might be the thing to do. Alison's just going to have to leave, but that's fine, Alison. Claire, did you want to come in at that point?
Yeah, sorry, just trying to unmute. Thank you, all the buttons. Yeah, I suppose my question is that I think the supervision of whether we use the IAPT people or the mental health practitioners is absolutely key, because I think this is something that makes people very anxious. And I was really interested, Nav, in your research about actually there isn't a risk assessment that is very robust in terms of predicting future risk, which I think in services we get quite caught up on having the right risk assessment and making sure risk assessments are completed, whereas actually we might be much better concentrating on that more holistic assessment, the sort of biopsychosocial, and rather than ticking boxes on the risk assessment. But that does make people feel safe, I think, if they think they've got a robust risk assessment. So I'm wondering how we manage that when actually there isn't anything that is particularly predictable of outcome around that supervision, but also timing, because even if you're talking about our mental health practitioners or our IAPT service, in terms of the responsiveness that you were talking about in your slide, in terms of that first, people are going to really self-harm, or it's going to be soon, I imagine all those parts of our service will have some element of weight. And so I suppose I know in Sheffield, when I developed a service for children and young people, it was our self-harm assessment team, so the sort of liaison team that wasn't psychiatry based, actually it was kind of all mental health practitioners who worked in CAMHS who did the rota. But they offered immediate follow-up to people after an episode of self-harm, which sometimes prevented them being referred into the mental health services at all. Sometimes was just a holding position until they're seen. So I'm just wondering if anywhere else has developed anything like that is actually linked to follow up from
presenting in hospital.
Yeah, there are some areas. Sorry, Clay, for me you were a bit crackly and fading in and out. So, but I think I caught quite a lot of what you're saying. So I mean, there are areas that are providing kind of follow-up. How rapid that is, I don't know. But Caroline will nod. She might know the areas as well. So I mean, Cheshire and Merseyside are doing kind of trying to do rapid follow-up, aren't they?
Yeah, I mean, they have a hospital-based system in Liverpool called Hopes, which is a rapid, it's a brief intervention, but they get offered it sort of right away, and within 4 weeks of their presentation, and they get 4 sessions follow-up. I think there's some evaluation work going on with that at the moment, but to, you know, anecdotally, it seems to be really successful, and everybody who takes part in it is they have a very high sort of retention rate. And
yeah, sorry,
did somebody say something then? It went really crackly.
Sorry, I think it's my internet is really slow and sorry.
Yeah, so there's the Hopes in Liverpool, and they've actually spun that out to one that they do for students as well at the university, which I think is called UHope or UCope, and we're trialing one in primary care as well, which is called Copes. So it's the same therapy, and it's offered, you know, within 4 weeks of a presentation for self-harm. They have 4 sessions, and it's, you know, it's a very kind of specified work that they do, but it seems to be working very well.
Yeah. There was the infographic from Frimley. Cornwall have got a psychologist in their ED department that's supposed to be providing follow-up. Oxford have got a kind of system as well. So Karen Lascelles in Oxford, I mean, it's more a kind of pilot service rather than a service for everyone. I think you know it's kind of getting going, but they're doing some great stuff there. I think, you know, the model for me, the ideal model for me would be the person doing the assessment does the rapid follow-up, because you know, if me as a service user, if I've seen someone, you know, and they ring me up, I'm much more likely to engage. So that, I think, would be the aspiration going forward. But Claire, you make a very good point about, well, kind of levels of resources, etc. But again, you know, it's a bit like building kind of slowly with IAP. You would, I think, you know, trialing that kind of rapid follow-up, perhaps through the kind of hospital service initially, would be the thing to do. The other thing I think that you mentioned, Claire, that was really important was, you know, who should it be? Should it be IAP? Should it be other people? I mean, in a way, it's not. It's tricky, you know, and I'm very well aware of real world, the real world kind of clinical realities, but it should be kind of everyone's job. So just making it one group's job is, I think, potentially tricky. So having a kind of multi-professional group who might take this on would be ideal. But the other really important point you talked about is, how do we make staff feel safe if they haven't got a form to fill in? And that's a really tricky issue. But it is about not focusing on the instrument, which, you know, actually the instrument then becomes a tokenistic exercise in protecting yourself, and focusing on the assessment. So I'd be, you know, we're encouraging organisations to focus on processes, you know, to develop, you know, training, but then make sure everyone's kind of trained, make sure people follow kind of best practice. So it's back to the assessment and the processes rather than the risk assessment. And then, you know, leadership within the organisation saying, no, you know, that's good enough. You know, if we go to the coroner's court and the coroner says, you know, where's the risk assessment tool, we can say, well, actually, we don't use a risk assessment tool, but here is the care this person received, and, you know, it was good. Or sometimes, you know, we have to hold our hands up as service providers and say, well, actually, we could have done this better. So it's focusing on the care people get, focusing on the processes, and hopefully kind of organisationally them getting the reassurance, rather than saying, you know, you've filled this risk assessment tool in, so you're covered, because actually you're not covered. It's providing false reassurance. Okay, I know that Lucy had a question around co-production. So Lucy.
Yes, we're grappling a bit with how best to approach co-production at the moment. So we've got quite grand plans at the start of our Wave 4 programme about you know, we'd looked at the co-production ladder, we'd done a lot of engagement across our system around how best to engage with people who've lived experience of suicide or bereavement and self-harm. And our ultimate goal was to establish a kind of co-production group locally where we could do some of that more in-depth work. So, for example, one of the things we wanted to do with them was develop a charter that we could then roll out across the system for suicide prevention and self-harm. That needs quite a lot of detailed work, doesn't it? Very slow burn, so very difficult to get people to engage with that group and to recruit members. The other thing that we were really, really concerned about is about managing the risk of people who engage in that process. We did spend a lot of time looking at that, and we've, as part of our Wave 4 money, we are paying Harmless to provide some sort of clinical support within those sessions and some follow-up support outside, but we're still really concerned with risk. So, and it's taken such a long time to kind of build up to that true co-production element. So in the interim, we are looking at kind of reaching out to people through existing groups and existing organisations where they've perhaps got some of that established support, but just whether there's any learning from other areas about how we can manage risk but still do some of that true, or aim towards doing some of that true co-production work, or are there different models that we could explore?
I'll let Caroline, you might have something to say about this through kind of coach and stuff.
We really need Leah for this.
Yeah, so we're
the expert on our group.
So Leah Quinlivan, who is, I think, visiting her mum in Ireland, and so we do let our staff have annual leave from time to time. So she's got some annual leave, but she's a real expert in this. She has set up a service user group, really, that advises on our suicide and self-harm studies. So it's a research service user group, but I mean, she's got amazing kind of buy-in from people. She's got amazing diversity on the group, because that's something we're often concerned about, that you get a service user group, and actually, you know, if we look at the diversity of people who are providing a service to, and then the composition of a service user group, there's a mismatch. She's done a brilliant bit of work there. She has, I think, fairly detailed kind of protocols about how risk is managed. But, you know, it's also about kind of empowering service users. So some, you know, I know that, you know, I had big concerns as well. I had big concerns. I remember back when, for our local, just our trust suicide prevention group, you know, our operational group, you know, we first started having service user representation on that. I was very concerned, but the people involved, you know, found it quite kind of empowering. They found it really interesting, and they had a really interesting effect on the way we all talked about suicide and self-harm. You know, really positive effect, actually.
Yeah, I think there's actually a lot less risks involved than you might think, because I mean, part of our message is that people should talk about self-harm and suicide. That it's, you know, it's not in and of itself a sort of triggering thing. And I have lived experience of self-harm myself, and yeah, I mean, the sort of people who tend to volunteer for these things are, you know, normally fairly, I can't think of the word for it.
Yeah.
Not, you know, they're volunteering. As long as they know what they're
signing up for.
Yeah.
We also started, when we first we're trying to recruit people, we put in a requirement that they would already be supported by an organisation, so we felt a bit more reassured. But yeah, we just still feel a bit concerned about it. I don't know if Helen Johnston was able to join us on whether she might want to expand on the question, because I know Helen's been giving it some thought as well.
Thanks, Lucy. Yeah, sorry, I snuck in, unfortunately, because I'm joined from another meeting. I'm Helen Johnston, I'm consultant in public health with Nottingham City Council. Now I'm newer to this agenda. We just started in my portfolio in September, and I've been seeking to understand with colleagues across Nottinghamshire our work on this. I suppose I think Lucy actually framed the question very well, because there was, you know, a lot of consideration. I think we're still struggling with the recruitment, and actually one of the things I'm grappling with is if we're going for a recruitment approach, then we're asking people to self-identify for a group and to be involved in the group. And then I'm also wanting to know how we can best engage with people where they don't have to necessarily identify as somebody who's experienced self-harm or suicide ideation, which is why that kind of mixed model that Lucy was describing in terms of some of our mental health forums. We've got quite a well-established mental health collaborative in the city, and it feels like we can have some of those conversations there. But that doesn't take away Lucy's underlying question, which is that over, to do that more detailed co-production work and to work with a small group, and really co-produce things, not just consult. We do need to find people who can give that more time, and I think that's one of the things we're grappling with. And actually, the problem is, as we learn along the journey, when we have tried to recruit, it's been quite small numbers, and those groups feel perhaps a little bit more exposing than we want them to. So, just grappling with this meantime.
But I think you've got absolutely that's really helpful, Helen. But you've got the beginnings of some of your strategies there. So one is kind of widening the group. The other is, I think, people don't necessarily need to self-identify. I mean, the other thing is, involving carers. I think that's really really important. But there will be people there. You just need to kind of find them. But I mean, the other thing I would like to echo is Caroline's point, is often as professionals, we're much more worried about this than the service users themselves are. The important thing, I think, is to have your protocols in place, so that the protocols are in place, to be mindful of, the fact that sometimes, conversations can be distressing, but, in the end, people have signed up for this, and the benefits of involving people with direct lived experiences is fantastic, and not just in the training. So you mentioned kind of supervision as well. We've mentioned supervision. If you can involve them in some of the supervision as well, it'd be fantastic.
And there are benefits to the people who are involved as well, the service users. If you offer them sort of training and information and support, then they actually get a lot out of it. And it can be, it can be really significant for some people, like it can really help them. Don't be too afraid of it. And the other thing is that I think Nav's already mentioned, you don't necessarily need people, that specifically have experience of self-harm and suicide. The broader range of people can also be useful. Just people who use services generally can also give good input to these things.
And of course, the other great reminder from this meeting is, you've got Harmless and Caroline and other people, on your doorstep. And so actually involving them, I'm sure, they'll be more than happy. I mean, obviously, there's the other thing that, I was initially didn't have my head fully around, which is making sure that, people's contributions are reimbursed kind of appropriately, and all the rest of it. So that all that kind of pragmatic stuff as well, I think.
The other suggestion I was going to mention was just approaching different groups. For example, some of the work that I've been involved in, we actually approached a group. We were looking for South Asian people, but we actually used a group that was in a different healthcare. It was actually a cancer support group, and we actually asked them. And people have come forward from that. So you can always reach out to other existing groups, with specific demographics if you want a mix of people involved.
But Lucy, what we can do is send you Leah's email address. Debbie, if we could send Lucy and Kate Leah's email address, and then we can take it from there. Hands up. So I'll let Claire come in first.
Yeah, sorry, mine was just an offer of Helen and Lucy, if you want any clinical support around kind of safety and making, if that gives some assurance to people about user groups, I'm more than happy to kind of offer that from a clinical kind of point of view, because I think, if that's helpful to get it off.
Wonderful. Thanks for that, Claire. It's really helpful. Louise?
Yeah, you've already offered Leah's email. I was just going to ask it. We've got a wider sort of issue as well around engagement in relation to co-production for the transformation programme as a whole. And we're trying all sorts of different approaches, and we're approaching sort of the voluntary sector and various different groups. And so it'd be useful to sort of understand sort of even how Leah sort of marketed and what sort of information she used around sort of things like that. Anything around that'd be really useful.
I mean, what surprised me is how successful Leah had been in getting people into the group, because and it's not just Leah, Donna Littlewood, another colleague that was involved, and Louise Gorman as well. So because in some senses, traditionally in my head, I had, service user patient involvement in developing services, which is, partly what this kind of thing's about, is easier to do than people being involved in research. But actually she's done well with the research. So although it's research engagement, I think it would benefit, it would be really helpful. So I don't know, Louise, if you would want to, if we're, once we've got in touch with Leah, I know she's very busy, but once you've got in touch with Leah, whether you might want to join the call with Lucy and pick Leah's brains.
Absolutely, yes. I think the learning from that we can share across all the different sort of areas that we're working on. Absolutely, thank you.
Particularly in terms of, if you like, protocols for if someone does experience distress and things like that, and having a unified kind of system, I think, can just kind of strengthen things. That's fantastic. Very good. Okay, I said we were going to finish by past, but of course, because we've got until 12, we've slightly expanded. But anyone got anything else they want to raise or ask us while they're here? Glenn.
Hi, Nav. Sorry for the delay in getting in. I've still got IT issues. Just a quick one. We spoke lots around co-production and pathway development, working with our agencies, etc. The project that you've got going in your area, what are you recording from from an outcomes perspective? Are you looking at things like ED attendance dropping down and patient feedback? Any particular outcome tools specific to self-harm that you've come across or working with?
So Glenn, I don't know if you managed to join the presentation, all of it, but I think the outcomes are really important. The approach really is you guys decide what you want to do, what your self-harm plan is going to be, and then we can help you decide how best to measure it. So on the slide copy we've got it. We call it a kind of self-harm data dictionary or a suicide data dictionary. So there's some suggestions there for some of the outcome measures you might want to use. But actually, one of my points was self-harm is really difficult to measure. So Caroline's spent.
I just wanted to say that I think we have the outcomes document on the website. Yeah. Which has quite a lot of detail on different ways you can report outcomes.
Yeah, but it's also about process as well. So I think definitely it would be good if you could say, well, actually, we've done this, we've got this great new service, and repetition rates for self-harm have gone down. It's actually really challenging to do, kind of coding and the rest of it. But you there are other ways you can think about how you demonstrate effectiveness, and asking people what they thought. And kind of process measures, but some of that details in the slides and on the website, but really important about measurement.
Thank you.
Very good, Louis.
One last question now, sorry.
Well, no, of course.
We'll move on. Are you involved in any of the developments with the SNOMED codes? Is there anything specific coming in the pipeline specifically for self-harm?
Well, Caroline was involved in the SNOMED codes. There is a SNOMED code for self-harm, I think, but I don't think there's any plans to refine that. Is there, Caroline?
I'm not aware of anything to do with the SNOMED codes.
Kate is going to have to leave. Kate, thanks for coming. I'll just say bye to Kate, but the rest of us should feel free to carry on. Sorry, Caroline.
I can't remember what I was going to say now. I was going to say, in terms of emergency departments, that obviously the coding, they use the ECDS coding now, they have matching SNOMED codes, but they are slightly different. But I don't know, and anything else other than that.
We get them for our liaison. I'm thinking more from community, but I can have a look into it. Thank you.
I think that it's a really tricky area, Glenn, and basically what you'll find is different areas code things in different ways. So it's quite tricky, and if you're using it to monitor outcomes, the most important thing is kind of consistency over time. So it may be that one of your codes is under inclusive, you're missing cases, but if you're looking to see what difference your intervention makes, that might be less of a problem, if you like. So consistency is really important, and casting the net wide. So quite a lot of things that, you know, might not be, quite a lot of things are self-harm that might not necessarily get a code of self-harm on administrative data systems. So cast the net wide, but also aim for consistency would be our advice. But have a look at the data dictionary, and we can, you know, Caroline, Leah, others can give you advice on data.
Perfect, thank you.
Louise?
Yeah, which is a question about national expectations from NHSC. So I know that obviously we've just recently completed the planning document for the submission for this year for SMI, and there's also a separate document for psychological therapies. And just wondering what might be the expectations from a self-harm point of view, and also sort of any future reporting.
Yeah, NHS England haven't told me about any kind of reporting requirements in relation to this. I think what, you know, if you like, we'd want to see, and, you know, what we hope you'd want as well is, you know, you end this 12 months with a kind of sustainable plan for what you're going to do for self-harm going forward. For the early implementer sites, we gave 2 rounds of formal feedback. Because there's, you know, 30 odd sites, you know, coming on board this time, we won't routinely be doing that. But, you know, if you want to show us your plans, if you want advice on your plans, we'd be happy to help you. But certainly not, you've kind of got a more detailed plan than many areas in the early implementer sites. So that's fantastic. You've got a really good basis there. I think what we tend to do is work with sites, to develop a kind of infographic, so people like the infographics are one-page thing. So, you know, at the end of the 12 months, you know, we'd help you develop one that then, you know, is something for going forward. So what you did, how you measured it, you know, perhaps you might have outcome data, in which case that would be included too. So that would be one of the outputs. As far as I know, no formal reporting other than the reporting that's in place for the community transformation program in relation to this work.
Thank you.
Great. Okay. Will we get a copy of the recording after the meeting along with the slides? Ian, we will make a copy of the meeting available. Do we send that to people, or how do we do it normally?
We have in the past sent the link by email to the people who attended,
right,
and left it open so that you can pass the URL on for these meetings. The launch meeting will be up on the website very soon. Yeah. We've now found out who does it.
And what do we do with slides generally? Do we just leave those on the website, or do we send those around as well with the link?
I'm not certain what we've done with the slides.
Okay. Well, if we can maybe just check what, you know, it'd be good to have a copy of the slides somewhere. You know, we might want to just have a generic.
We can send them around and put them on the website later. It's not a problem. Okay,
fine. I'll leave that, Ian, to yourself and the team then to send the link round and the slides. If there's no other questions, I'll let you go. Probably lots of people have got meetings at 12. Just time to grab a quick cup of tea before the next Zoom or Teams meeting. It's great. Fine, no more hands up. Lovely to see you all. See you all soon. Important part of this is staying in touch. Renee, thank you so much for coming. You know, hopefully that's been helpful to kind of get things.
Yes, thank you. Yes.
And again, you know, the offer is very much, you know, stay in touch with us, and we want to help in any way we can, because we're really excited to be involved in this.
Thank you very much.
Thanks very much. Bye, everyone.
Bye. Thanks. Bye.